Vitality.
Vitality Unfiltered.
Unfiltered.
With David Bauder.
And we're back for another episode of Vitality Unfiltered. I'm David Bauder, your host today. With me from Weight Loss and Vitality is from Riverhead, New York, is Dr. Shah, and from Washington, D.C., Stephanie Lattimore, nurse practitioner extraordinaire. All right, so today we're going to be discussing statins. And it's really not one of my favorite topics, but we're going to discuss it anyway, okay? It's Dr. Shah's favorite topic, so that's why we're going to get at this. Statins have been one of the most prescribed medications for decades now. And I would say the last 20, 30 years, statins have been heavily prescribed medication. And only recently, a new medication class has taken over the number one spot, actually, on prescriptions, and that is GLP-1s for weight loss. And so it still is a worthwhile medication to talk about because it is actually one of the more controversial medications to talk about. And that's what we want to get at today is talk about the risks, the benefits. Is there risk? Is there benefits? Who should be taking it? Who shouldn't be taking it? And kind of peel that all out. Okay. So to start off with, we know that statins lower LDL. Okay. When people hear cholesterol, let's flesh this out a little bit. Too many people, I'm going to start off right by saying this. Too many people are so concerned about the total cholesterol number. It is by no means the whole picture. And there's a lot of new evidence that's coming out that suggests other things have a bigger role in predicting cardiovascular disease. And this is what we're going to use as a metrics to try to determine who and what patients would be benefiting the most from using a statin medication. So let's start with what role do statins play on LDL?
So statins reduce LDL, but first of all, they're lowering the entire cholesterol number. They're HMG-CoA reductase inhibitors, and they empirically lower cholesterol. But then the subdivision of cholesterols all across the spectrum from very high density lipoproteins to very low density lipoproteins empirically get reduced. Some are better at lowering the LDLs as opposed to the HDLs. We technically don't really want to be lowering the HDLs, more so the LDLs. The reason is that the atherogenic particles are thought to be the LDLs, right? The low density lipoproteins. These are small cholesterol molecules. This is how cholesterol is being transported through the bloodstream. So remember, cholesterol is a lipophilic molecule, and so it's hydrophobic. So it can't just go through the bloodstream. It has to be put into like a little packaging vesicle. That's what these molecules are. Would it be all right if I just kind of talked about atherogenesis? It might help the listener. So, atherosclerosis doesn't occur in a vacuum, and it's not just the fault of the LDL particle. Like, these particles are naturally occurring, okay? There is a kind of a trifecta, like a perfect storm that has to happen for atherogenesis to occur. One, there has to be endothelial disruption, right? So these particles have to be able to break through the endothelium. This can happen in the setting of hypertension, breakdown of the glycocalyx barrier of the endothelium, free radical formation in the endothelium. And then once it gets in, there has to be a chronic inflammatory state to then attack that LDL particle when it gets stuck there. So all of this has to happen for that plaque to form. So this is just one strategy to reduce atherosclerotic risk, but in the correct patient, it is valuable.
So what you just described is the total cholesterol component of how it attaches. That's how it forms the plaque.
Yeah,
is through that process that you just described. And HDL, what's the thought on how HDL has the protective component to this?
It's not so much the protective component, but it's really just shifting the ratio over to more HDLs than LDLs. Like if you can decrease LDL output from the liver, in fact, LDL gets formed from HDLs going through the bloodstream, and then the subsequent tissues taking out the cholesterol particles, HDLs will become LDLs. So like LDLs are like kind of where cholesterol molecules reduce into, but we just want to decrease that burden as much as possible.
I see. And so with a whole bunch of clinical studies and a whole bunch of data, we are kind of under the assumption that the people that benefit the most from statin use are the individuals that already have had a coronary event.
That one is very clear. So the reduction of all-cause mortality from cardiovascular risk is usually like the heaviest weight is in those populations that already have ASCVD. The big controversy around statins is how universally prescribed, like you were saying, like prior to GLP-1s, like they were just being prescribed like, I don't know what else is like hot. It's like they're selling like hotcakes, I guess. Right. I don't know. Like it was just a lot. And that's where I think a lot of the contention had come from. Cardiology circles were basically, I mean, some cardiology circles, joke that it should be in the water. And that's where I think the pushback has come from. And I think the culture is getting better around that. I think we are getting better about figuring out the correct candidates. And for example, actually in the very recent guideline update, the 2020, just in March of 2026, the ACC-AHA, American College of Cardiology and the American Heart Association came out with a new guideline update to indicate that even in patients who have normal LDL, it is worthwhile to check ApoB and Lp(a), which are subdivisions of LDL particles that are thought to be particularly atherogenic, and especially in patients who have familial or genetic predispositions to forming more of those particles. We know that reducing those particle numbers empirically reduce ASCVD risk. So that's where I think this industry is headed. I think statin use is going to become, it's a slam dunk in patients who already have ASCVD. But I think in a lot of our patients, we're more in the preventative side. We have to start thinking about men and women who are in their 20s, 30s, 40s, whether or not to introduce statins, whether or not to introduce lifestyle factors first, follow their particle numbers and see the trend and see if like we can avoid using statins. Like this is where the conversation starts with the patient.
All right. So let's move on to risk or side effects. So what do we got?
So in this widely prescribed category of medication, statins, and for the listeners, that's going to be your Lipitor, your Crestor, anything that ends in statin as the generic. 10 to 20% of patients may develop side effects, but for the most part, statins are pretty well tolerated. Let's just drive that point home. But I will talk about some of the more serious side effects like rhabdomyolysis, like muscle breakdown. Up to 20% of patients will have temporary muscle pain, muscle cramping, especially in the legs. That's the big one. Some GI upset. And then there is documented in the literature some neurological, temporary neurological changes, dizziness, side effects such as those.
And you have you have some data that would suggest that isn't.
Yeah, so that's what's purported, and I think things have been. No, there are definitely side effects. Now, there's just been like a phenomenon that has occurred, which is that because they're such a heavily hated on medication on the internet, particularly like certain circles, and in particular the myalgias component. So there's a study, I think it was a European trial. I have to look it up for you guys. We can put it in the show notes maybe. That looked at over like 10,000 patients in a placebo-controlled trial where we looked at the incidence of myalgias after the initiation of statin therapy. And what they found was that there was the incidence was high. Myalgias do occur. But what happened was the same amount of myalgias occurred in statin patients and placebo patients. So whatever is happening right now in our social milieu, whatever has gotten into the ether, patients are there. There's a certain subset of patients who are convinced they will get side effects from statins, and they are correct because like they will manifest those side effects. That's how bad it has become. So they're an incredibly well tolerated drug, but it's kind of gotten out of proportion to what's should be reality, but that's unfortunately like our new reality. It kind of reminds me of like gluten intolerance. Gluten intolerance was very in vogue for a while now. Now you don't hear about it as much, but like everyone was gluten intolerant for a while, but it was just like the popular thing to have. I see it that way. So, but when I counsel a patient, I explain that the side effects are incredibly mild, and I typically start at very low doses. And I think that's something to drive home to patients too. Like we can risk mitigate right now with low doses. We can also do lifestyle factors to like drop tons of weight, increase muscle mass, optimize nutritional inputs. And then you can trial off of it and to see how the numbers look. And if you're happy with how the numbers look, then you're not on statins anymore. Or if you just feel better being on them, it's an individualized approach. You decide for yourself.
Now, I'll go on the record and say that I'm a statin skeptic by and large. And when I did prescribe a statin last week for the appropriate patient, I did educate him if you do feel any muscle pain, muscle cramping. Did I plant the seed? I don't know. Like
No, because they already know about that.
Okay.
Everyone knows about that at this point.
But as the prescriber, I'm thinking, what's the worst thing I can? And this patient was a really good candidate for statins, right? Smoking history. He has since stopped, but extensive smoking history, family cardiac history, which was kind of hard to get out. You know, patients don't always know, but he said that his dad had stents and whatnot. There you go.
There you go. Yep.
Overweight, obese, uncontrolled high blood pressure. You're probably a good candidate for statins and lifestyle management. But what I was going to say was I think what's the worst thing that could happen to this patient? Rhabdomyolysis, elevated liver enzymes. So I did bring him back in 6 weeks to check his LFTs, which were mildly elevated as they may be, mildly. And I...
Secondary to his other stuff, probably.
Absolutely. Yeah. And then you like you said, start at the lowest dose, monitor for side effects. These medications are titratable.
Very titratable.
So you don't always think of that. It's not just like you throw this, and just because they're so widely prescribed doesn't mean they're safe or appropriate for every patient. I brought him back in 6 weeks. His LDLs were within normal range. They were normal. So
they work.
It worked. The science is there. He tolerated them very well.
Yeah.
I will put in a refill on Monday. So
I love that you mentioned this specific patient because it brings up the point where I have a problem with statins. The universal prescription of statins should not be at the expense of lifestyle modification. And this is the problem that we see in primary care, right? And it's not the primary care physician's fault or the family practitioner's fault. If you have a panel of like thousands of patients, if you're seeing 30 patients a day and you have to reduce their all-cause mortality from ASCVD, statins are your best bet, right? Because like you can prescribe statins like this, fast, right? It's very hard to do a smoking cessation talk. Very hard to talk about nutrition, a nutritional plan, an exercise protocol. That stuff takes time, but that's the durable change that we are looking for. For me, I focus on that first, personally, because I can afford that in my practice. Because when I do visits in my practice, I have 60-minute visits, 30-minute visits. Our practice is different, right? But this is where I think a lot of the problem comes in. It's just that quick knee-jerk, fix a number with the pill kind of medicine. And that's, I think, where the social milieu of this comes from. You know, it's like, it's a more complex and nuanced disillusionment with the system as a whole. Like, it's not just statins cause myalgias and that's why people don't want to. People want better care. That's what it is, I think.
Yeah. And what you said too about the lifestyle, each one of those takes time to do. The exercise takes, the nutrition,
smoking cessation.
Cessation.
You're smoking cigarettes and you're getting a statin. Like, you need to stop smoking cigarettes.
Each one of those could be a visit.
Yeah.
Each one of those specific visits, those issues. And then you also, and I see this in the clinic. It's sometimes hard to tell a patient that they should be on blood pressure medications.
Yeah.
And you said right at the beginning, the endothelial damage. There has to be a break. There has to be something that caused damage. Now that can happen for several reasons. But one of the main reasons that happens is blood pressure.
Yeah, sheer stress from chronic high blood pressure.
That's right.
Like if you have chronic high blood pressure, remember, blood pressure is an area under the curve phenomenon. Like if the pressure in the hose is high all the time, it's a problem. If it's only high when you go see Bauder, it's not a problem. Like that's just white coat hypertension.
It's a different problem.
It's a different problem. But like if it's high all the time, plus you're smoking cigarettes, you're introducing free radicals into your endothelium.
Coffee.
Plus, Plus, you have visceral adiposity, low dose chronic inflammation. Plus, you have very high caloric input. Your triglycerides, your LDL particle number is high. That is like the perfect storm.
It is.
You have to attack all of them. And that's what's missing. You cannot just prescribe statins in a vacuum. That's where I think the problem is.
And blood pressure is a great example. You don't prescribe a blood pressure medication the first time you meet somebody. Right. You can't diagnose hypertension without 2 readings on a different day, right? A different office visit. Statins are the same way. I'm not going to read your lipid panel and say you get a statin today without discussing diet, family history, other risk factors. I've had patients whose LDLs are off the chart and their cheese snackers, little diet modification can go a long way for some patients.
I'm going to circle back one more time to this blood pressure conversation because this gets me. With how we treat blood pressure is like if they come into the clinic and it's high, this is how we've been programmed. If they come into the clinic and it's borderline, sit down, wait for 15 minutes, we'll check it again. That is not reality. That is not reality because when these people go to work and they're working and they have stress at work, what's their blood pressure? It's high.
Yeah.
Or if they go to the gym and exercise, it's high. the reality is what I look at it like, how many people get to go and take a time out at work to settle down and calm down and allow their blood pressure to settle? No, high blood pressure is high blood pressure. And sometimes we'd be like, okay, check it first time in the morning when you wake up when it's the lowest. Well, why are we doing that? Like, why are we going and trying to find the lowest possible reading throughout the day to not justify medication? Because odds are 80% of a patient's day is going to be in a high stress situation and they're going to have high blood pressure.
Yeah, it's an unfortunate reality. Plus with caffeine intake and things like that. That's why I do recommend, not to belittle trending blood pressure, but just to empower the patient. It's not a bad idea to take multiple readings throughout the day. That's actually what I usually do with the patient. I find the reading in the clinic to be, it's just, again, one data point. If I see the trend at home and it's high, like while they're just kind of sitting and eating lunch, that's a pretty good indicator that they have hypertension.
And what are the lifestyle considerations that we were talking a little bit of lifestyle, like obviously that needs to be the foundation approach to what we're doing. What are you telling the patient?
So when I draw a lipid panel, which I do on every patient, regardless of age or weight loss journey, I do like to break down the different types of cholesterol. High density lipoprotein is very important. Healthy cholesterol, I want this number to be above 40. That's going to be your omega-3 fatty acids, right? Fatty fish, cooking with olive oil, avocados. I want to incorporate those things into a patient's diet and let them know that cholesterol does play a really important role in the body, and you do need cholesterol. It's been proven to be neuroprotective and have really good benefits. LDL is going to be more of your low-density lipoprotein, as Dr. Shah mentioned. This can be affected in some patients through diet, limiting the red meats, the dairy, the animal products. So really want to get to know them. I don't want to assume anyone is just eating poorly, right? There's a huge hereditary component to this as well. So just getting to know their family history, their lifestyle, check their blood pressure, screen for other risk factors, modifiable risk factors being smoking, obesity, non-modifiable being the family history, and just go from there and treating each patient as an individual. This is a good time to tie in menopause. Women who go through menopause, on average, their LDL will bump up by 10%. I wouldn't prescribe a statin without discussing hormone replacement therapy as an optimization tool in that category, in that population. I also wouldn't prescribe a statin just because a woman is going through menopause and has no other risk factors.
Right.
But I've seen it happen a lot of times.
Times have changed so much, because if we go back 6 months ago, prior to the FDA coming out and finally backing down off of the women's health initiative, that same postmenopausal woman with the 10%, 15, 20% increase of their LDL cholesterol level, they wouldn't be given hormones. They would have been right off the bat given a statin. And it wouldn't have been even in the conversation to be like, wait a minute, we ought to be thinking about your estrogen right now, because that has endothelial protection. All right. And that's protecting the lining of the vessel. It's funny how that works out. I also think about too many, like you commented about the important role of cholesterol. It's absolutely true. I mean, cholesterol, your adrenal glands that make, some quality hormones, that's where they come from. If you don't have good cholesterol coming in your body, they're made from healthy fatty acids in your blood.
It's a fundamental molecule. Like your cell walls require it. A lot of hormones require it. It's very, very important. Cholesterol is not bad. We have to risk mitigate specific particles that we know are atherogenic. And I think really focus, if your PCP is not ordering ApoB and LP(a), they're actually already behind guidelines, because these came out in March of 2026. And I think insurance, we have an argument, I think, to say that insurance must cover them.
They should, must cover them. And we've talked previously on other shows too about doing lab tests here and now, and getting the current. It's also about trending. But then, we hadn't really thought about bringing this up, but, we talked a little bit about genetic testing and the role of coronary artery disease. And it kind of puts a person in a situation. We do genetic testing at Weight Loss and Vitality through a company called Extending Me. And there's a specific genetic testing package that they do called the metabolic panel. And in that metabolic panel, they look at all your genome types, and they look at your propensity of getting coronary artery disease later on in life. And how I've said previously too is I've always said that current labs represent here and now. Labs drawn in 6 months from now represents the trend, and your genetic test represents the blueprint of where you're headed, right? And so my, on my metabolic genetic testing, it showed, I got some possibilities coming down the road about genetic testing, or I got some possibility of coronary artery disease. It makes you wonder how you should approach that, right? Because, you can do the lifestyle, and everybody needs to understand the lifestyle are the foundations for everything we do. I mean, if you're not doing the eating, the exercise, if you haven't checked for sleep apnea, all of these things matter, and hormone regulations and gut health, all of this stuff matters for the foundation. But it makes a person wonder how early on should you do this? If you know you got a genetic test that says that's going to happen, but you got a CT calcium scoring test at 0, you're sort of controlled cholesterol, but you still got this blueprint for the future about where that's going. Is it reasonable to start a statin?
I think it's totally up to the individual, and that's why I think the individual risk profiling is so important. We're not and I love that we're getting away from this treating a number phenomenon. We're not doing that anymore. All right, like we're looking at individualized risk factors, their age, their lifestyle, their dyslipidemia, or their lipid panel. Now we're looking at genetic predispositions. According to these guidelines, there is a role for statin therapy in your early 20s and 30s, even if you have severe familial dyslipidemia. Like that's an empiric benefit. We know that for a fact. And every patient's going to be different. Like I'm just going to give you a personal example. Like if my lipid panel continues to trend kind of like in this moderate risk situation, and then like I'm presented with an option of either a low dose statin or cutting out steaks for the rest of my life, I'm probably going to choose a low dose statin, because like I like eating steak. And again, everyone's different. And I have no shame in admitting this, because every patient is like, your life and the life you live, you decide what you want to do. Like if a ribeye is the thing that gets me in the grave 5 years early, I'm okay with that. That's like totally okay with me. That's how much I like beef. But everyone's different. Same thing with you. Like if you wanted to start that low dose statin and then trend your risk over time, that's fine. But if you also just want to not start it and just like check your lipid profile in a year and a year thereafter and just revisit that, you can also start a statin and stop a statin.
I know, I did
start a statin. Yeah. It's like there's nothing like, it's not permanent. And again, I think it's another one of these area under the curve phenomena. It's like the more time you spend in more optimal control, the better off you will be. Plaque formation happens slowly over time. It's not an all of a sudden phenomenon.
But it does happen early. What's remarkable?
It starts early.
It starts very, very early. A while back, I read something about, it's kind of a horrible story, but they looked at, actually in the 1970s, they looked at young men coming back from the Vietnam War, and they were doing autopsies on some of the fallen soldiers. And even those 18-year-olds, 19 and 20-year-olds, they were seeing early plaque formation in their heart. Way back then. Yeah. Now, granted, there was a lot of smoking taking place.
A lot of smoking, a lot of drinking.
Yeah, a lot of that taking place at that time. But it starts a lot earlier than we think in the plaque formation. You guys have anything else to add?
I read a study that I will cite in the show notes that they took a large cohort, patients on a statin and not on a statin, and the statin patients lived on average 7 months longer than the non-statin patients. And what that told me was there's just way too many variables in this scenario to control. That was kind of like a nothing burger of a study. But if you're someone who wants to eat steak every day and you'd give up 5 years of your life, like I think that's kind of a good point. Like 7 months, I think lifestyle, the bottom line is lifestyle, right? If you want to live longer, live well, manage your lifestyle, have these conversations with your provider about what is really specific to you and what meets your needs and minimizes your individual cardiovascular risk long term.
Yeah, good point.
Yeah.
Yeah, great conversation, guys. I want to thank you both for being here today. If you enjoyed the show, make sure you click the link below so you don't miss the next episode. Just remember that this all starts with lifestyle. That's the foundation approach. Statins, they are effective, but they're primarily used to manage risk and mitigate risk on certain patients. And please don't discount the lifestyle changes that are needed, all right, as the foundation. All right, thank you for being with us today, and we'll see you on the next episode.
Thanks for joining us on Vitality Unfiltered with David Bauder. Addressing norms, busting myths, and uncovering health realities for a more vibrant life today. For more expert insights and real talk, make sure to subscribe and join us next time.